list there. And we're going to talk about the prostate, what it is, what it does, and the problems that it can cause. So the prostate is an organ in the male genitourinary tract. It sits, if you look, there we go, thank you. If this is the bladder here, and it holds the urine, the urethra drains the urine out of the bladder, and here at the base of the bladder sits the prostate, this organ here. So this is the front view of it. And the prostate's function is mainly in reproduction. It produces fluid that supports the sperm and the health of the sperm for reproduction. And it just happens that once you're out of the reproductive years and don't need it anymore, then it starts causing you trouble. And part of that, and if you remember this here, is because of the way that it's situated, where you have to pee through the center of the prostate, like you're peeing through a donut hole. And that can cause issues. So what kind of problems can you have here? So the prostate, you can get cancer in the prostate. Probably everyone's heard at some time of prostate cancer. You can get what's called BPH, which is enlargement of the prostate that causes urinary symptoms, and then you can also get infection in the prostate. Those are the main issues that men have with their prostates. We'll talk mainly about these first two. So prostate cancer is the most common internal cancer in men. About 1 in 6 men will develop cancer over their lifetime, so it's quite a high number. The thing that's somewhat reassuring about that is that only 1 in 30 men will die from their disease, which means that most men don't die of prostate cancer even if they have it. So there's a saying that you'll die with prostate cancer, not from it, usually. But there's still a significant number of men will die from prostate cancer, and that's prostate cancer generally that has spread outside of the prostate and causes problems. And so the goal is to, if you have prostate cancer, catch it early so it can be treated. Now, the average age of diagnosis is about 65 years old, but prostate cancer can come at an earlier time. So rarely comes before you're 40 years old, but even in your 40s and up through there, it's possible to develop prostate cancer. So how do you, what risk factors are there? So if you have a family history of prostate cancer, especially a first-degree relative like a dad or a brother, that puts you at a higher risk of prostate cancer. And that's especially if that first-degree relative got their prostate cancer at a young age. That means that you have a genetic predisposition for prostate cancer, potentially. Also, men from African descent have a higher risk of prostate cancer, and then the biggest risk factor is just getting old. The older you get, the more likely you are to get prostate cancer. And there's some estimates from studies they've done on autopsies of people who have died for other reasons. Once you get up into your 80s, almost 80% of men will have some cancer in their prostate that they didn't even know about. So again, going back to the saying that most men don't die of prostate cancer even if they have it. So a lot of people ask, what can I do to prevent prostate cancer? And they've put a lot of research dollars into studying what you can do to prevent it. And unfortunately, there's no proven prevention currently. So they've done studies looking at different vitamins and supplements, and they found that none of those help prevent prostate cancer. In fact, one study where they were doing high-dose vitamin E, the men had more prostate cancer in it. The biggest potential link from what it looks like now is diet. So our Western diet with processed foods, et cetera, is not the most healthy diet in the world. And what they've done is if you look at population studies, populations that follow kind of a more rural, kind of traditional diet that's made up of mostly whole foods and plant foods, they don't tend to get as much prostate cancer. But when they adopt a Western diet, then prostate cancer rates start to go up. Again, that's just kind of a observational study. There's still no proven prevention for it. So then if you can't really, there's not a lot you can do apart from just trying to be healthy overall to prevent it, then what we have to do is screen for it, because it kind of hits people randomly. And so we want to find who has it and treat them if it happens. Now, the problem with prostate cancer is that in the early stages, there are usually no symptoms. So you don't know if you've got it. And that's why screening methods were developed to screen men to see if you have prostate cancer so we can catch it early and then treat it. Now, if you have advanced prostate cancer, you can get some symptoms, trouble urinating blood in the urine. Prostate cancer tends to spread to the bones, so you can have bone pain. But the problem is if you wait for these symptoms, then it's too late to cure it, because that means it's outside of the prostate or really far along. So there are two components of prostate cancer screening. One is called the PSA, which is a blood test. PSA stands for prostate-specific antigen. We'll talk more about that. The other is the digital rectal exam, which is the dread of coming to the urologist is the rectal exam. So we'll talk about that too. So first, PSA is a chemical made by the prostate, just part of the prostate's normal function, and it's only made by the PSA. That's why it's called prostate-specific antigen. And it gets released into the bloodstream, and we can detect that in the blood as a marker. Now, the reason that we use that is every prostate makes PSA, and everyone makes a different baseline level of PSA. But prostate cancer cells make more PSA than normal prostate cells. And so that's why when you have prostate cancer, your PSA goes up. But the PSA, again, can be raised by other issues. So if you have a big prostate, more prostate makes more PSA, not necessarily cancer, so your PSA can go up. If you have an infection in the prostate, if you've had a catheter in, urinary retention, even recent sexual activity can cause the PSA go up. Some guys we see who are cyclers, they ride on a bicycle for hours a day. Just that pressure from the bicycle seat can even sometimes press on the prostate and cause some inflammation and release PSA. So the whole point of this is that PSA does not diagnose prostate cancer. All it does is it gives you a risk. It kind of raises a red flag, lets us know that maybe there's something we need to look into. And so it used to be that if your PSA hit a certain level, we'd do a biopsy. And now there's a little more that goes into it. We watch the PSA over time and see if it's rising over time. We have discussions about where your PSA's been, kind of these kind of activities to see if a biopsy is actually necessary. Now the other component is the digital rectal exam, which is, as it sounds, a rectal exam with the finger, which is not particularly pleasant for you or for me, but can give us some good information. So the digital rectal exam, as it shows here, the prostate sits right next to the rectum. So that's why we use that method. It's not just because we're mean, but it's because that's the only way to feel the prostate. Now, what you can feel, if there is a cancer here in the prostate, it feels hard. The prostate should feel pretty consistent. If you make a tight fist and feel kind of that part of your thumb there, that's sort of what it should feel like, kind of like a firm, rubbery consistency, but prostate cancer will be hard. The issue with the rectal exam, again, is it's not perfect, just like the PSA isn't perfect, because if you had a cancer up here in the front of the prostate or over on the sides, you wouldn't be able to feel it through the rectal exam. That's why these are screening tests. They cannot diagnose prostate cancer. So who should be screened? So the recommendation is that all men starting somewhere between age 50 and 55 should start getting screened for prostate cancer. If you have a family history or you're a higher risk for prostate cancer, it's recommended you start at 40. Get a PSA at 40 years old. And then screening, as the recommendation is screening should be stopped. If you haven't had an elevated PSA by the time you're 70 or 75, then you're likely not going to develop a significant prostate cancer. The other thought now, again, is kind of taking into account life expectancy. So if your life expectancy is less than 10 years and you develop prostate cancer, you're probably going to die of something else, because prostate cancer generally is very slow growing. Go ahead.
So higher risk family history, like my grandpa died from it, is that
So, it's probably enough that it's worthwhile looking into. Again, the closer it is to you, the more strong the risk is. So it's not, if it was your grandpa, that's not as strong as if your dad got or brother got prostate cancer, but that still puts you at a higher risk because it is in the family somewhere. So it's probably worthwhile at least getting a PSA checked if you're in this age range. And a lot of times, and some people have even started or recommended at age 40 you get one checked just to see what your baseline is, because it should be low at age 40. And then if you're in the really low risk group, then you don't have to get another one checked until you hit 50. So that's a discussion you could have with your doctor about that. And then again, so this is kind of a loose number because there are a lot of healthy 70-year-olds out there that have 15, 20 years left, and so those guys might benefit. But if you're a 70 or 75-year-old and you only have a few years left, it's probably not worth screening for prostate cancer at that point. So if you are at risk, if your screening kind of raises red flags that we need to know if you have prostate cancer, the way to diagnose that is with a prostate biopsy, which is also not a pleasant activity. It's done in the office, similar to the finger exam, except instead of a finger, there's a small ultrasound probe that goes in the rectum. And that lets me see the prostate. And through that probe, there's a channel where you can pass a needle that takes core samples of the prostate. So basically, you take samples of the prostate out and send it to the pathologist. They stain it, and they get something that looks like this. And the pathologist's specialty is to know whether these cells look normal or whether they look like prostate cancer, and that's how the cancer is diagnosed. Now, if you do get diagnosed with prostate cancer, it's not as bad as being diagnosed with some other aggressive, fast-moving cancers. That's why there's that 10-year life expectancy, is because when you develop prostate cancer, it's about a 10-year process before you'd start having problems from it. So in some men, if they have very low amount of disease and it's a low-grade, kind of slow-growing cancer, you can actually do what's called surveillance, where you just watch them over time. Because what has been discovered is that some cancers just will never progress. They'll never cause you trouble. And so that's again a change in prostate cancer treatment that's happened over probably the past decade or so. Is it used to be any prostate cancer was treated, and now there are some that probably don't need to be treated. Now, if you do have a more aggressive prostate cancer, then there are two ways to go for trying to cure prostate cancer. And one of those is surgery to remove the entire prostate gland, and the other is radiation therapy to kill the cancer within the gland. Now, if the prostate cancer has spread outside of the prostate and has become metastatic, then there's no real chance of curing that, and we just try to contain the disease with hormone therapy and chemotherapy to try to keep the cancer from growing and causing more issues. So the whole gist of this is that you need to get screened, because if it's caught early, you can cure prostate cancer and live a full life afterwards. But if you let it go, then you have issues. So before we move on, do you guys have any questions about prostate cancer specifically? Yeah.
Why is it that African Americans have higher risk?
It's just so they don't know why. Something genetically, just from being of African descent, they found that those men have higher rates and a higher grade of cancer. So they don't know specifically what it is. It's just genetically, it's a different thing. So those are just from like population studies and following over time. That's kind of what has been shown. Any other questions? So let's move on to the other issues. The other big issue you can get with prostates, which is benign prostate overgrowth. So it's called BPH, benign prostatic hyperplasia. So this is much more common than prostate cancer and affects many more men than prostate cancer does. And this is where, if you take a look here, if you have your normal prostate with a good channel through it, you can pee easily, you have a good stream. But just depending on your genetics, prostates continue to grow over time as men age, and the cells grow and keep dividing. And in some men, you'll get overgrowth that compresses that channel. Again, like you think of the prostate like you're peeing through a donut hole. That hole just gets tighter and tighter, and then it makes it much more difficult to get the urine out. And so this can lead to, well, we'll talk about the symptoms, but it's very common. So it's estimated that by the time you hit 50, about half of men will have some issue with their prostate, with urination. And again, as you age, it becomes more and more common. And this is usually not something that you wake up one morning and you say, oh no, I'm having problems. It comes on very slowly. And so what happens to most men is it becomes your new normal without you knowing it. Just kind of slowly progresses. And these are the conditions. So there are two results from having that obstruction. First is just because the channel is smaller, you get what's the obstructive symptoms. So there's a slower stream. You get hesitancy where you go to stand at the toilet and you have to wait for a minute to get things started. Starting and stopping, and then incomplete emptying. You just don't empty your bladder as much. Now so your bladder is a muscle. When you urinate, it's not just by gravity. Your bladder actually pushes the urine out. And so as that channel gets tighter, the bladder has to work harder. And just like any other muscle, the harder you work, the stronger the bladder muscle becomes. And in the bladder's case, that's a bad thing, because the bladder then squeezes harder than is normal, and it squeezes more often than normal. So what happens is you get what we call these irritated bladder symptoms. So that's frequency, going too often, urgency, where the urge hits and you've got to run, you can't postpone it. Nocturia is waking up at night. And then for some men, if the bladder spasms get severe enough, they can't even hold it back. The bladder just pushes the urine out. So the treatment for those sort of prostate issues is just getting the channel opened up bigger. So if you can relieve the obstruction, then the bladder can kind of calm down, not squeeze so hard, and you can get rid of those symptoms. Usually the first thing we start out with medication. There are two classes of medication. One class to relax the prostate, and the other is to shrink the prostate. So some of the medications we give to relax, like Flomax and Rapaflow. There are a lot of also generic medications that you can give that actually relax the tone in the prostate. And then the other ones are these Proscar, finasteride. These are the generic names for them. Those actually block the hormone signal that the body sends to the prostate to make it grow. So those are two ways that you can treat these symptoms. Now, the downside of medications is as soon as you don't take a medication and it gets fixed. You take a medication to maintain the symptoms, and if you go off the medication, your symptoms come back. And then, like anything else, medications can have potential side effects. So the common side effects of these ones that relax the prostate is they also relax some blood vessels. So some guys, when they stand up fast, they'll kind of get lightheaded. This can also cause some sexual side effects, just because of the relaxation of the muscles around the prostate. And then these medications that shrink the prostate, their main side effects are also sexual side effects, so some erectile dysfunction, potentially decreased libido and that kind of stuff. So they're not totally benign, although most men who take them don't have bothersome side effects. Now so the other options, if the medications don't work for you, or you have bothersome side effects, or just don't like taking medications, the other option is, again, the goal is to open up the channel inside the prostate. So if medications aren't going to work, or you don't want to take medications, then we move on to a procedure to open up the prostate. So the one that's been around forever is called the TURP, the transurethral resection of the prostate. And some people call that a ream job or a Roto-Rooter. Whereas basically you go in, you go to sleep in the hospital, and a urologist like myself would go in and carve out the inside of the prostate. So this shows that here. If this is the prostate and the bladder here, this white represents the overgrown prostate. So there's a little tool you can use. It's basically a wire loop that an electrical current runs through, and it cauterizes and cuts. And you just take swipes of the prostate from the inside, and you get these little chips of prostate. You get a big pile of them at the end. But what you end up with is a wide open channel like this and then the obstruction's gone, you can pee a lot better, you resolve those symptoms. This is a relatively, it's not like a big open surgery, but you are disrupting, you're cutting all along the lining of the inside of the prostate, so there's bleeding that's involved with that. You have to stay overnight. This little bag here is the guy's catheter bag, because this fluid runs through the bladder, washes out the blood, and takes it to a bag. And then you have bleeding on and off for a couple weeks, so there is some healing goes along with it and some risk of the surgery, but it does open up the channel and relieve that obstruction. Go ahead.
So once you have that surgery,
Mm-hmm.
is it possible that you have to have that surgery again? Like if you have, like the problems would come back?
So it is possible because, again, the prostate continues to grow over time. So even though you've removed that tissue, it still grows back. This is not removing the entire prostate, just the inside. And so again, depending on your genetics and how fast your prostate grows, some guys, within 6 or 7 years would need something done. Most guys, well, for a lot of guys, you just need a one-time. If it's going to grow back, an average is probably more like 10 years that you'd start seeing symptoms again. So another option for getting things opened up is what's called Resume. This is a newer procedure that's been, it was FDA approved about 3 years ago. The benefits of this is that it's not a hospital procedure. It's more minimally invasive procedure that's done in the office. And this uses hot water vapor to basically kill the overgrown cells inside the prostate. The nice thing about this is it's lower risk than the TURP because you're not cutting out the prostate. So there's lower risk of bleeding. You aren't disrupting the inside of the prostate. And there are also less side effects because of that. And let's see. So I got a video here. There's just kind of is an animation of how that works. So let me see if I can get it to play for you here. So this is exciting because there really haven't been any other great options that have worked well besides the TURP. Let's see if this thing will load up. And if not, that's fine. I'll just explain it to you as well. So this procedure is done in the office. Like I said, it's done under local numbing, and basically a scope is used to go in like a catheter, kind of like the other procedure would do, except instead of cutting out the prostate, there's a little needle that pokes into the prostate and delivers hot steam inside the prostate. And what that steam does is it kills the cells inside the prostate. And then your body reabsorbs those broken down cells. And so as it reabsorbs those cells, the prostate shrinks down and opens up the channel. The difference with this procedure is that you go home the same day, but because, just like anywhere else, if you get an injury, the body's first reaction is to swell up. So the prostate swells initially, can even swell your bladder shut so that you can't urinate. And so you go home with a catheter for about 3 days that you wear at home, and then take the catheter out. And initially, you're still dealing kind of with the healing, the swelling for a week or two, but then starting around 2 weeks, things start to get a lot better, and that keeps improving. And at 3 months, guys are doing really well. So that's an exciting option for. I know that nothing about the prostate, I'm sure, seems exciting, but for us, where all we've had is kind of a more invasive option, it's good to have more options for people who are suffering from those conditions. So in summary, this is, maybe that's not going to cut. So in summary, if you have, so prostate problems are extremely common. So most men, sooner or later, are going to have some issue with the prostate, whether it be a prostate cancer or urinary issues. But the good news is that they're treatable. So the important thing is to just catch them in time, especially with the prostate cancer. Because there aren't any symptoms related to it, it's important to start getting screened. So that's usually done through your primary care, your annual physicals. They just do the rectal exam and the blood test to screen for the prostate cancer. And then if there are any concerns about those levels, then you'd get referred to a urologist to look into it further. So I'd encourage you guys, if you haven't done that and you're in this age range, to look into it. And then as far as the urinary symptoms go, the driving factor there is how much it bothers you. So if you're bothered by your urination, then your urinary symptoms and start to impact your life, that's the time that you go and get it treated. So that's also something you could either talk to your primary care about or find a urologist that could help out with that. So I'd be happy if any of you have any issues or would like to come in, I'd be happy to talk to you. I do have a office here in Brigham City. We started this month, so it's convenient just over at the hospital there. Or I'm also have an office down in Ogden, depending on where you live. But that's basically it. You guys have any questions about any of that? Mm-hmm.
I thought we had two good questions from the
Yeah.
last seminar. I can't remember what the one was, but it was on sexual activity.
Yeah, we just did this up north, and one guy had a question about these treatments, the TERP or the Resume, the steam treatment on sexual function. So the Resume is the first prostate treatment for enlarged prostate that doesn't have any sexual side effects to it. So every other prostate treatment that's come before that has some negative impact on sexual function. Now, even though that's potentially minimal, that's still also good news that there's something out there that has less side effects. So we've been happy with that. Anything else?
Why can't you just remove it?
Right. So, and I get that question a lot, that if you don't need your prostate, why can't you just take it out? And the problem with that is that, there aren't that many symptoms from just opening up the inside of the prostate. But when you take out the entire prostate, as we have to do sometimes for prostate cancer, then you have potential for long-term side effects. So when you remove the whole prostate, there's about a 5 to 10% risk that you'll have long-term incontinence, so trouble holding in your urine. There's probably almost up to a 50% chance of erectile dysfunction after removing the prostate as well as complications from surgery and scarring after surgery and that kind of stuff. So that's why you don't just go kind of willy-nilly remove the prostate. So that's reserved for cancer. All right.
I have
Yes.
urology, more so than a prostate question.
Mm-hmm.
But say someone is like mid-30s, doesn't have a history of prostate cancer in their family, but who gets up a lot at night, or like just urinates a lot, like during the day or at night, whatever.
Mm-hmm.
Could that be a prostate issue, or what?
It can be. So again, just like prostate cancer, the enlarged prostate usually comes on later in life, but some men develop it earlier. There are other things that can lead to urinary frequency and getting up at night. So if you drink a lot of fluids, everything that goes in's got to come out. So that's one. A lot of guys will drink a lot before bed, and then they're peeing all night. And so we'll sometimes do what's called a voiding diary, where you track how much you drink and how much you pee and when you pee. So that's one option. Other thing is that some people's bladders are sensitive to a different degree to bladder stimulants. And the one that we most commonly see is caffeine. So caffeine stimulates your bladder to squeeze more often. And so if your bladder is sensitive to caffeine, you'll find that you pee more often and you get stronger urge to urinate. The other thing that caffeine does is it's a diuretic, so it causes your bladder to fill up faster. But in some men, and usually if men have these issues and it's not due to fluid intake, we see young men like this and they have what's called a high bladder neck. So it's the way that their bladder formed at birth is that the opening to the bladder is too tight. And the opening of the bladder is kind of this muscular ring. And so some guys will have what's called a high bladder neck, where instead of a smooth exit to the bladder, there's almost like this dam that the urine has to go up and over. And so we see that not infrequently. And in those guys, it's just the way that it's usually not the prostate, but you get the same prostate symptoms because it's obstruction. And so those guys, sometimes the medications work to relax the bladder neck, but a lot of times we have to go in and do what's called an incision of the bladder neck, which is a couple little cuts along that tight ring, and it pops it open like that. And those guys usually respond really well to that.
Questions? I know you guys are all thinking about that digital record.
All righty. Well, appreciate you guys coming in this morning. And if you have any questions or anything, we can get you my contact information if you want to call or make an appointment or whatever. All right? Thank you.